we've talked about anatomy and physiology. We've talked about electrophysiology. Electrophysiology, it, as y'all can tell, goes much deeper than just the SA node, AV node, and all that. It goes to the cellular ionic level. And it even goes much deeper than the topical way that we presented it to you guys. That's the way I can present it to you, and that helps me understand things, okay? Now we're going to start moving towards why y'all really want to take this class and what we really want you to get out of this class, all right? And that is to understand what them little stickies are showing me when I stick them on the chest. That is to understand how a monitor works. That is to understand, I've got this on the monitor, what do I check to treat this patient, all right? There's two phrases that are cliche, but I use a lot because I'm a corny person, and that is, number one, you play like you practice. You heard me say that last week. So whatever we do in class is the way that I want you to perform out in the field, all right? Let me take that back just a little bit. I want you to perform like you're going to perform in the field in class. Okay? The second one. This is the most important, and it's really not cliche. It is the most important and the most crucial. You treat the patient and not the monitor. You treat the patient and not the monitor. You will hear it so much that I hope at the end of the year y'all will get me a Yeti cup that has that phrase on it. I'm just kidding. I'm not shooting for y'all to get me anything, but my last class told me that so much. That's the one thing that they remember from me is that I said you treat the patient and not the monitor. All right? But that goes across all of your diagnostic tools. So in this class, we will mainly focus on the cardiac monitor. All right? With airway, we will mainly focus on capnography, end-tidal CO2, and SpO2. You know, when we treat a patient with diabetes, our diagnostic tool is the glucometer, all right? Those are just diagnostic tools. We have to do a good assessment on our patient in order to know exactly how we're going to treat them. Let me go ahead and throw this out there right now. Let me ask you a question. Do you diagnose in the field? And before you start shaking your head, yes or no, I want you to just take a moment and talk. I want you to talk to your partner that's at your table. What do y'all come to a conclusion, okay? If you're by yourself, just get with somebody in the front of you. But y'all tell me just for about a minute. Do you diagnose in the field? All right. Y'all think I've come to a conclusion? All right. All right. Morris, I heard you say something just a minute ago. Stand up and tell us what is y'all's thoughts on it?
Field diagnosis.
Field diagnosis. So you're saying that you do to a degree diagnose in the field. All right. All right. We'll come back to that. Oh, good thing that wasn't open. Quick hands, quick hands, quick hands. Stand up and tell me.
Well, you have to go through a differential diagnosis in order to keep your patient alive to get them to the hospital. So to a degree you do, but not an official diagnosis.
Okay, all right, that's back. All right, Rob, what you think? Good hands, good hands.
I mean, we think the same thing. I'm not going to confuse that.
All right, well, thanks, Rob. Thanks, man. Is there anybody that disagrees with what they just said?
Let's look at field impression. To me, I think the field impression is different than a field diagnosis.
Okay.
So in my impression, I might think what's wrong with them and go all through the correct channels, from what I think and believe is wrong, but it's up to the doctor to diagnose.
Okay, all right. So it's in the terminology that you use, though. Field impression and field diagnosis, okay? Diagnosis that goes on the Medicare chart that they go home with, no, we do not. but we do form a field impression. We do form a field diagnosis through a process called what? Differential diagnosis. You have to. There's no doubt about it. You have to. You've got to use the assessment skills that you learned in your previous EMT classes and building on this class and tomorrow's class and yesterday's class. You've got to use those tools, and you've got to form a field diagnosis in your mind. And it's okay for you to come out and say, I think this is what's wrong with this patient based on what they're presenting. Because if you don't, then how are you going to know how to treat this patient? Right? You've got to be able to treat this patient. These monitors are only going to tell you so much. A blood pressure, SpO2, heart rate, glucometer. Those are just objective numbers that are based off of what the body is telling them based off of their testing techniques. The most important tool that you're going to have is your 5 senses and your ability to think. Alright? Is to touch that patient. Is to see that patient. Is to hear what that patient is telling you. Is to, in some cases, smell that patient. Or smell the odors off of that patient. I'm not going to make a point just to go sniff somebody. Alright? Okay, your 4 senses, because let's make that 5th one you're thinking. Alright? Let's not be tasting nobody. That's just nasty. Alright? You get where I'm going, so let's move forward. I tell you, I say silly things not on purpose, 99% of the time. I don't have to tell jokes, all I gotta do is talk and y'all will laugh. Alright. So what we're about to do is take a step off into EKG monitoring. To understand how the EKG monitor works, you gotta understand what it is. It is a graphic representation of electrical activity in the heart. The body or the heart has 2 functions. It has the electrical and the mechanical. This will only tell you what's happening electrically. Okay? It is a very important diagnostic tool. As a paramedic, any medical patient that you have and any big trauma patient that you have should get at least a basic strip ran on in at least 2. Okay? It will help you identify cardiac abnormalities in the electrical system. Now, based on your knowledge of how the electrical system works and what a complex looks like, then you can expect the mechanical function, or you can look at it and you can kind of expect what portion of the mechanical function is going to be affected. For instance, if I look at a monitor and I see that I've got atrial flutter, I'm going to look on the monitor and I'm going to see flutter waves in the atria before I get to the QRS. Then I know that the electrical activity has been affected in the atria. So therefore, I'm going to be able to put those 2 together and say, hey, there's something that's affecting the pump in the atria. I may not be getting a full pump in the atria. Alright? Flip side, I may see ventricular tachycardia. Alright? Something that most of y'all should be familiar with at this point. I don't see any atrial activity, so I know that the atria either is trying to work, but is being overridden by the ventricle, or just the ventricle is firing. Based off of that. Is that always the case, though? Is that always going to be 100% foolproof? No. That's why you treat the patient and not the monitor. You look at the monitor and you form field impressions in your head, field diagnoses in your head based off of vital signs, based off of monitoring, and then based off of your physical assessment. Because there will be rhythms that we see here that we're going to expect signs and symptoms that relate to that particular rhythm. All right? Remember, the whole purpose of us treating a patient is to try to improve what? Cardiac output. Cardiac output. So whether we're looking at the electrical or the mechanical, we're trying to improve cardiac output. All right? So here's things that can be obtained from an EKG strip. Anything to do electrically, your rate, your rhythm, time intervals, conduction pathways. It cannot tell you how good it's pumping. It cannot tell you the cardiac output that's being put out. It cannot tell you what a blood pressure is, and it cannot tell you the condition of the cardiac muscle itself. How would we know that the heart is having a good pump? How would we know that the heart is pumping decently or good? All right, we're going to check pulse. We're going to check blood pressure. And we're going to look at overall perfusion status. Okay? I can't hit this enough to where if you see something on the monitor, that's just a step in your treatment of your cardiac patient. Okay? All right. When you evaluate an ECG, you're going to have to use a systematic approach. Everything that we do is going to be a systematic approach. All the way down to your assessments and to anything else. Think about it. You form a system to memorize things. You form a system to interpret things. You do it the same way each time so that it gets easier and easier and easier. Once I start teaching you the 5 steps of rhythm interpretation, you will use those 5 steps for every rhythm that you interpret. All right? And then as time goes on, you're using those 5 steps, but you're not going through them individually. You're able to just look at a strip and you can see that it's regular. You can see that it's rate. You can see that you've got a P wave. You can identify, hey, that P wave is prolonged, that PRI is prolonged, or you've got a wide and bizarre QRS. So over time, you will be able to see that. But until that point, you will use the 5 steps that we will bring up probably next week. All right? So, electrical activity is sensed by the electrodes placed on the skin surface. You'll hear this term a lot, Einthoven. It's a name. Dr. Wilhelm Einthoven, back in the early 1800s, looked at some experiments that were performed by these French scientists back in the 1700s that they figured out a way to make a frog's leg contract based on stimulating it just a little bit. All right? But Wilhelm Einthoven is who we consider the father of cardiac monitoring. All right? And he had several different things that he did that were very rudimentary, but what it led to was this. We put leads on, they pick up the electrical activity, they turn that electrical activity into something that can be traceable and readable, and it comes out on your monitor. This is called an electrocardiogram. There is a difference in an electrocardiogram and an echocardiogram. An echocardiogram is an ultrasound. That can tell you ejection fraction. That can tell you cardiac output, things like that. Electrocardiogram. The screen on the electrocardiogram. Although it is now digital, it is called an oscilloscope. Oscilloscope. Has anybody paid attention to my past 2 class days of what I had up on the screen before class started? Y'all come in. I'm going to just have clips of it playing every day that I can, but that's emergency. That is the start of, really kind of the start of modern EMS based out of Los Angeles Fire. What's really neat is that there's not been a lot of things that have completely changed since then. And so it's pretty neat to see that. But if you see the monitors that they use, you'll actually see that it from time to time when they show it, it looks like a seismograph that they detect earthquakes with, where it's just a needle that burns a little line on. So that's really what the oscilloscope is. It just went to digital now. All right. Now, because the heart, it generates very low voltage, the electrodes take that and they amplify it through the cardiac machine. Electrodes and leads, I think we should have a pretty good understanding of that, but when we talk about leads, we'll talk about leads as positive, negative, and the ground. All right, when we get to leads, because there's going to be different lead views based off of the way that it's going towards the positive or the negative electrode. So that's where we say leads. Leads doesn't necessarily just mean the plastic stick or the sticky that we put on the chest. Okay? Voltage. When we look at the monitor, when we look at the rhythm, what we're seeing is a depiction of the voltage that is being generated by the action potential of the myocardial cell. The action potential of the myocardial cell. So if I've got a complex that goes up, I know that that is a positive deflection. And if I've got a complex that goes down, I know that that is a negative deflection. So when I'm looking at a complex, if I see a waveform that goes up towards the sky, that means it is a positive deflection. If I see a waveform that goes down towards the ground, that means it is a negative deflection. I know that this may seem very elementary. But what this actually means is that if we see a positive deflection, it means that the electrical current is traveling towards the positive electrode or the positive lead. And if we see negative, that means that it is going away from the positive lead to the negative lead. All right? And that's what this shows right here. I like to write it. Now there's another term when it comes to looking at your strip. That is the isoelectric line. The isoelectric line is going to represent the cell's resting potential. When we see the line, a black line, flat, we're going to see that the cell is not having any type of depolarization occurs. Now we also will use that area as a point of reference when we're looking at other types of waves, such as T wave elevation, ST elevation, and things like that. Okay? All right. Essentially, what we're trying to do is we're trying to get different views of the heart. So ECG leads give us different views of the heart based on which leads we are using. All right? We're just trying to see the whole thing. All right? If you're selling something, if you're selling a car, you're going to take a picture from the front, then the side, then the back, then the other side to get the full view of that car before you sell it. And that's essentially what this is. It gives you a different perspective based off of what view you're trying to see of the heart's electrical activity. All right? So, to begin with, you're going to have what's called bipolar leads. Also, your standard limb leads. These are what are you're familiar with. This is where we put the electrodes on. This is for routine monitoring. This is where we put the 4 electrodes on. We've got salt, pepper, ketchup, and turnip greens or relish or whatever you want to use, okay? You can also do clouds over grass and smoke over fire, whatever you want to do. Just know that it is going to be white, black, red, and green. Now, these are called limb leads for a reason. Technically, they are supposed to be placed on the limb. So you can get a reading if you place it on the arms and then at the bottom on the leg. What you cannot do is get an accurate reading if you place the leads, the top two on the chest and then the bottom two on the legs. If you do chest, you need to do chest with all four. If you do arms, you need to do arms and legs. Okay? So this is going to be leads 1, lead 2, and lead 3. What it's going to be is lead 1 is going to give you a perspective, lead 2 is going to give you a perspective, and lead 3 is going to give you a perspective. Then you go into what's called unipolar leads. Let me back up. Standard limb leads are called bipolar leads because they depend on two poles, a positive and a negative, and they are created by the leads themselves. Unipolar leads, AVR, AVL, and AVF, also known as augmented leads, they're going to depend on what's already there to create the negative, and they're going to have a positive. You'll see this more clearly in just a moment. Augmented leads are called augmented because they emit very, very, very low voltage. And so when it goes through the monitor, it has to actually augment that to where it's actually a readable voltage. Okay? Then you have precordial or chest leads. Who's done a 12 lead? Who's put a 12 lead on it? Alright? That's what those are. Alright? So you've got to have your standard limb leads placed before you can do a 12 lead EKG. Alright? And it's called a 12 lead because it combines these 6 leads and this 6 leads. Okay? Initially, your precordial or your chest leads, the 1, 2, 3, 4, 5, 6, they are going to give you a view of the left ventricle. Alright? The electrical activity in the left ventricle. Alright? From, you'll have a septal view. So the septum, interventricular septum. You'll have an anterior view. You'll have an inferior view. And you'll have a lateral view. Lateral being to the side. Okay? Why do you think initially, if you think that somebody is having an MI, why do you think it is important that you first take a look at the left ventricle? Alright. What now? Alright, so it's your main source of perfusion to the body. It is your largest ventricle, right? But also, when we're looking for MI, what we're really trying to detect is coronary flow, right? We're trying to look at that coronary to see if we've got coronary artery obstruction. Well, what do we know about the left side? You've got the widowmaker. You've got the LCA, which is the widowmaker that supplies 80%, 85% of the blood. And it's going to be on that left side. So there's several folds there. You've got the biggest, most important ventricle to pump to the body. Also, you've got you got to take a look and see if you've got some left-sided coronary involvement. Now, on down the line, we'll get into 12-lead interpretation, and we will give you, I'll show you what to look for to make you move leads to say, hey, I've got a right-sided infarct or something with the right side. But for now, while we're learning the basics, you've got your 3 standard limb leads, you've got your 3 augmented limb leads, and you've got your 6 precordial chest leads. Okay? Just a really quick, to make sure we're on the same page. P wave, what does it represent? Atrial depolarization. QRS complex. Ventricular depolarization. And then the T wave. Ventricular repolarization. Now, just by looking at this, without us getting too deep into the voltage right now, why do you think that the QRS complex is so much bigger than the P wave? Think of the size of the ventricle compared to the atria. The atria require voltage to contract to have their action potential, right? But look at the size of the muscle in the ventricle. So it takes much more electricity to power the mansion than it does to power the single wide trailer. Alright? So it takes much higher voltage to power the large chambers than it does the small chambers. Okay? Y'all good? This is not quite near as gut-wrenching as the first lecture, is it? Okay. ECG Graph Paper. So what I want you to do is take your paper, get you a pencil out, pen, whatever. Alright, I want you to have it sitting in front of you just like this, where you see the printed in the United States, it is at your chest. Alright? That's the way that you're looking at it. Okay? Earlier, I mentioned that when we look at a ECG rhythm, we're looking at it in milliseconds. Milliseconds. Alright? If you look at it like this, from right, let me see how y'all are looking at it. Alright. From this side, from left to right, that is going to represent time. Alright, so it is a graph. Then from bottom to top, that's going to represent amplitude or voltage. Okay? Yeah, sure. Yeah. Alright? So what I want you to do, I'll explain it to you in a minute, but look at the bottom here. You'll see a little bitty tick mark. Alright? Find your first little tick mark, and just somewhere up above that, I want you to count 5 of the thick pink squares. 1, 2, 3, 4, 5 up. And then 5, 1, 2, 3, 4, 5 to the left. Alright, and then just make you a box. Circle that box. So you should have 5 small boxes going up and 5 small boxes going to the right. Just make you a square, just like that. All right.
I have a question. I think this is like 5 to 6 boxes.
Let me finish what I'm doing right here. Should look like this.
Okay.
All right. I just want you to make just a box. All right. So, inside of that box, you will see thick pink lines that make up 1, 2, 3, 4, 5 small boxes. All right. Each one of those boxes is going to equal 0.20 of a second. Each of the small small tiny boxes is going to equal 0.04 of a second. All right? So each tiny box represents what? 0.04 of a second. So if you combine 5 of 0.04, you're going to have a 0.20. All right? So it takes 5 tiny boxes to make a 0.20. How many of the 0.20 boxes is it going to take to make a second? 5. All right? Now, going back to your paper, is everybody on the same page with me right now? Everybody on the same page with me right now? All right. If you go back to your paper, and if you look on that tick line that I told you to find, if you find the next tick line, all right, that's going to equal 3 seconds. The next tick line after that, 3 seconds, so on and so forth. Write this down, make a note, remember this. Anytime that you're interpreting a strip, you need to at least have a 6-second strip. So you need to at least have enough complexes, or you need to at least have enough paper that you've got 6 seconds. And that's why those tick lines are there as a quick reference. So once you get used to seeing it, you will notice that. Okay? EKG Graph Paper, it leaves at a constant speed. It is calibrated. It has to go at a speed of 25 millimeters per second. All right? It has to go at that speed in order for it to be calibrated correctly between the heart's rhythmicity and what we're trying to depict on the graph paper. Each small square is 1 millimeter in width with a time interval of 0.04 seconds. Okay? So we've already established that. So it's going to be important to understand that you've got the 0.04 second boxes, and then you've got the combination of the 0.20 boxes to make the 1 second box, to make the 3 second strip, to make the 6 second strip. Okay? But when we start interpreting the rhythms, we are going to be looking at small boxes because we're going to be looking at the length of the PRI or the QRS or the ST or the T-wave. We're going to be looking at the small boxes to count because we're going to need to know how long they are. To put it in perspective, the longer a contraction is on the paper means the longer that it is taken for the heart to contract. Okay? That's why we need to know that. And we're going to have baseline numbers. We're going to have normal numbers here in just a few minutes. Okay? I've got 11 o'clock. Y'all need a break for a few minutes, or do you want to keep going and then we'll take a break in just a little bit? All right, let's roll. Okay. So this is everything that I just told you. Got your 3 seconds. Your 6 seconds. You've got to have that. All right? So if a small box is 1 millimeter, then you know that the large 1 second box is going to be what? You're going to have 5 by 5. All right? I'm sorry, not the 1 second box, but the box that makes up, okay, the 0.2 second box. It'll be 5 millimeters by 5 millimeters. Now, we will get to where we're looking at measuring height in millimeters. not as important when we're looking at just basic arrhythmias and stuff. What gets important is when we start looking at ST elevation and things like that, because we want to see the actual height that it is. Okay? You following me so far? You following me? Yes, that is a tiny box. Yes. Mhm. Yes. Yes. So your tiny box is 1 millimeter, and it's 1 millimeter in size, and it's 0.04 seconds in time. Okay. So the small boxes are light lines. You got the darker boxes that's going to divide it into every fifth square that's going to give you a 0.20. Alright? So dark line to dark line is 0.20 seconds. Okay? Light line to light line is 0.04 seconds. Alright? So a small box, when represented by time, is how long? Everybody, a small box is what? 0.04. A larger box with 5.04 boxes in it is going to be 0.20 seconds. 0.20 seconds. All right, are we good on this? Are we good on the time? All right. I told you last week that we try to keep high energy and we try to keep you activated. We don't really have any way to keep you engaged on this part. Once we start getting into that stuff, we get more engaged. I know that it's a little boring, but we're getting there, okay? So that's just repeating. Repeating is very, very important. All right? Positive and negative deflection. A positive deflection is going, so if I see a deflection that is going upward, it is, if I see a deflection that is going downward, it is negative. What is that line called that just hangs out there in the middle? The isoelectric line. The isoelectric line. Okay? All right. We're going to breeze through this next section real quick because it's just talking about the things that we've already talked about. You got your SA node. Well, let me just say this real quick. 0.10 seconds in length. How many small boxes would that be? 2.5. It would be 2.5 small boxes. All right? Don't worry about that as much as this. The PRI. This is going to be the time impulse, travels from the SA node, makes its pathway to the pathways, and then down to the AV, where it's about to get ready to make a contraction, a ventricular contraction. All right. So the PRI is the interval between the P wave and the R. And it's a little worded weird, but it's actually the time interval from the start of the P wave to the start of the QRS complex. Okay? This is important. Write it down. 0.12 to 0.20 seconds. So if I saw a PRI, if I was looking from the beginning of the P wave to the beginning of the QRS complex, and I saw that it was one large box, I would know that it is 0.02 seconds, or 0.20 seconds. Okay? Got that wrote down? And of course the QRS X complex represents ventricular depolarization. Understanding now with deflections, we can understand the complex a little bit deeper. The Q wave is going to be your first negative deflection. Your R wave is going to be the first positive deflection. And then your S wave is your next downward reflection after the R wave. And then as the S comes back up, it is just trying to go back to the repolarization state. This has got to be less than 0.12 seconds. So the start of the Q wave to the end of the S wave has got to be 0.12 seconds. So far, we've talked about the PRI. The PRI starts where? Beginning of the P wave, and it's measured to the what? Beginning of the QRS complex, okay? The next thing we're going to measure is the QRS complex, and it starts at the first downward deflection, right? So the Q, and it goes to the end of the T, or the S, sorry. What we're actually looking for is, at the end of this, we're looking for the place called the J point, the point where the S wave ends and the T wave begins. We'll show you that in a second. All right?
The measurements you're giving right now are those, that's normal?
Yes, less. Or yes.
Less than 0.2?
Yes, it's less than 0.12. Miss Curry will probably tell you 0.08 to 0.12. All right? I'm telling you anything less than 0.12. All right? Because a QRS gets, you will hardly, if you see a QRS, you're not going to see it get much lower than 0.08. All right? That's going to be normal parameters. So normal parameter for the PRI is what?
0.2.
Is 0.12 to 0.2 seconds. Normal parameters for QRS is anything less than 0.12 seconds. Okay? Then you've got the ST segment, which is going to be the interval between which the ventricles have depolarized and now they're going back to their resting potential. All right? You should be getting to about right there, the S, QRS, T. So the point where the S and the T meet. Okay? There's no numbers for that. What we look for in the future is going to be ST elevation or ST depression. So we may not be looking at time abnormalities with that, but we may be looking at voltage abnormalities with it. All right? Or amplitude. And here's the thing. If I've got a QRS complex and I start seeing that I've got a slower depolarization to repolarization right there, that means that it's taking my heart longer to get back to its resting state, and it's telling me that my heart is having a hard time, and I may have some ischemia in the cells. Okay? And then you've got your T wave. Your T wave is going to be very important that it looks rounded and a positive deflection, because there will be things that influence the T wave. The T wave is a direct reflection of the cardiac resting. So just as important in the cardiac cycle is the depolarization, it's just as important for the repolarization. With the P wave should be rounded, upright. The QRS, it should be a sharp look. Your Q wave shouldn't be very deep, and it should be less than 0.12. And then your T wave should be upright and rounded. Okay, so that's the summary of those. All right. I've told you about the limb leads. I've got 11:10. I need to take a break to get a sip of water. Let's take back to 11:20. And then we'll get started back on this, and we'll get monitors out in just a few minutes and show you. All right, so I told you about the standard limb leads. You've got your bipolar leads, lead 1, lead 2, and lead 3. The next ones you've got augmented leads, AVR, AVL, and AVS. Then you've got your precordial leads. So we're going to take these lead by lead. We're going to talk about it lead by lead, and we're going to put it on, and we're going to talk about it. All right? Your bipolar lead. So in order for you to get a tracing, you've got to have a picture of that electrical impulse traveling either towards the positive electrode or away from the positive electrode. If I've got an impulse that's traveling towards the positive electrode, it is going to be a what deflection? Positive. If that impulse is traveling away from the positive electrode, it is going to be a negative. All right? So the term bipolar means that there are two poles. You've got a negative and a positive pole. What's going to happen is the monitor, based on what lead we tell it we want to see, is going to turn the pole into negative or positive. Okay? Now, on our mannequins, including the other ALS mannequins, this is my 12-lead simulator here, we won't use sticky pads. We will have direct hookups to the mannequin. All right? If and when I'm going to put the electrodes on, where am I going to stick the white one? All right, right shoulder or the right side. If you look on the white, it says RA or right arm. All right. What's next? And if you look on it, it says LA or left arm. All right. Then below, it's going to be red or left leg. All right. So these again are your limb leads. Pay no attention to these right now. All right. And then you've got your green or your right leg. All right. So our bipolar leads, the recording that we're going to get off of this monitor is going to be based off of my right arm, my left arm, my right leg, and my left leg limb lead. I will just for purposes of demonstration. Actually, I might wait for some brand new. All right. So my bipolar leads are going to be lead 1, lead 2, and lead 3. They're going to form a reference line from positive to negative. All right. In lead 1, this is going to be the difference in electrical potential between the left arm and the right arm. All right? So in lead 1, the left arm lead is positive and the right arm lead is negative. So what this is going to kind of give me a view of is across the heart. Lead 2 is going to be the most useful quick loop lead because your reference is going to be positive left leg, negative right arm. You think about the anatomy of the heart, the SA node, AV node, and all that. Your point of reference, your reference line, where you're getting your picture from, is going to follow along that track. Okay? I don't know if it'll be easy for you to look at it like this, but if I'm doing lead 2 I'm looking at the electrical conduction of the heart this way. The axis is this way. That line of reference is this way. Essentially, the way to think about it is that I've got a camera that's taking a snapshot of the electrical conduction coming towards me. Okay? Same thing with lead 1, path. Alright? And then the same thing with lead 3. Lead 3, we're going to have a positive left leg and a negative left arm. So it's going to get more of a look on this side. Alright?
On the top of that, where it says standard eliminates your core difference, should that left leg be positive electrode?
Because the left leg's negative up there, but the left leg's positive down here.
Yeah, it changes. It changes. Yes. It
Polarity?
changes. Yes. Mm-hmm. Yep. It changes.
The left leg changes polarity?
Where does it say?
Up top it says left leg negative.
Left leg negative, left low.
Okay, so yeah, for these three, it's going to be positive right there. So yeah, you're right. So what I want you to see here is that I'm going to do a little drawing. All right. If I think of the stick man here. All right, he's got little V arms because I don't want them to get in my point of reference. All right. I've got my heart here, all right? I'm going to take a look this way for lead 1, all right? Then I'm going to take a look this way for lead 2, all right? And then this is going to turn to a negative pole if I'm looking at lead 3, and I'm going to take a look that way, all right? So what do those axes, those points of impulse, those lines of impulse is actually called an axis. What do they form? A triangle, right? So that's where Einthoven's triangle came in. Now, you'll see in your book, it's actually not necessarily a triangle, all right? It's more of a look like this across the heart. But to simplify it, he made it into a triangle. Okay? For you to think about that reference. So each line just depicts how the picture is being taken. Alright? So, let's look at it. If I am trying to get a lead 2 view, where is my positive electrode or my positive lead? The left leg. So my negative is going to be my right arm. Alright? Let's say for whatever reason I wanted to look at lead 1. Where is my positive? Left arm, negative's right arm. Alright? Let's say I wanted to get a lead 3. My left arm turns to what? Negative, and my left leg turns to positive. Alright? I don't have to do anything but just tell the monitor which lead I want to look in. Alright? It knows how to change the poles. Could have just showed that picture, but I like to draw. So again, the axis of lead 1, I've got my positive left, negative right. Lead 2 is this way. So if you just imagine this line coming up to cross the heart, the point of the heart, it's going to go more along the lines of the normal SA AV conduction system. Okay? So it can give you a couple of little points of reference for anomalies if you've got a different rhythm than just a normal sinus rhythm. In reality, I guess what you'd want to think of is you would want to think of it more of the heart, where lead 2 is looking that way, lead 1 is looking that way, lead 3 is looking that way. Okay? Einthoven's triangle is going to be the basis of your bipolar leads. Okay, your standard limb leads. So understand about Einthoven and his triangle grid. Each lead just gives you a different view of not the heart muscle, but the electrical conduction system of the heart. Okay? Your augmented limb leads. So our standard limb leads are leads what? 1, 2, and 3. Then just off of these 4 leads right here, we can have 3 more views. AVR, augmented right, augmented voltage right, AVL, augmented voltage left, or AVF, augmented voltage foot, or left leg, foot. Okay? So these are actually unipolar leads. Now, does that mean that they only depend on a positive lead to get a picture? No, it doesn't. What it means is that it combines two negative electrodes to form that negative lead. All right. Yes. Mm-hmm.
If we're only looking at the heart 3 ways, why do we put the right leg lead on?
What do you mean? Why do we?
Like,
The right.
'cause
That's your
sometimes-
ground.
Sometimes on the church
Yeah.
they'll only do a 3 lead.
Right, and that's what this is.
So
This
why
is
do
that's
we-
your ground. That's your ground line.
You always have to always.
That gives you a ground there. Mm-hmm. We'll get more into that. But for now, just understand what those, because in reality, the old monitors used to just have 3 leads. But that last one incorporated is a ground. Okay? Now, I really want you to start becoming proficient in looking at lead 2. Initially, as we're doing strips and we're practicing strips, they're going to be a lead 2 view. Okay? But you do need to have a basic understanding of your augmented. You're not going to do much of a diagnosing with augmented until you do 12 lead stuff. And even if you're doing a lead 2 and you see something that stands out, you've got to do a 12 lead to really do your field diagnosis and things like that. Augmented limb leads, they use 3 electrodes to provide their view of the heart. 2 of them are negative, 1 of them is a positive. Okay? They intersect at different angles. Alright? So this is a point of reference. Einthoven's triangle is essentially a point of reference of where these lines intersect. So these are going to add a couple of more. This is going to form what's called the Axial Reference system. I don't expect you to walk out of here as experts at this today because there's just really no way for me to explain it until you've read over it some. Alright? I'm going to try to, but AVR again means right arm is positive. Alright? So if I'm looking at AVR, I'm looking at a view where it's going to combine these 2 to go there. Alright? If I'm looking at AVL, I'm looking at a view that's going to combine these 2 to go there. And if I'm looking at AVF, then I'm looking at a view that's going to make those 2. Okay? Positive for AVR, positive for AVL, positive for AVF. Whoa! Look at all them lines. Look at all them lines. So we can get a little bit better view of this. Don't worry about these numbers right now. This is actually just the axis, or the degree of the axis, the degree in which the axis is going from positive to negative. All right. What we're looking at is, if you think of the hexaxial reference system as the point of impulse starting at the heart where they all intersect. Then lead 2 would be here, all right? Lead 1 would be there, which is the same thing as we saw. Lead 3 would be there. Then you've got your augmented leads, where you've got your AVR, your positive is going that way, your positive for AVL is going that way, and your positive for AVF is going straight down, all right? Don't get hung up on this right now. In this, we're looking at the direction that the positive is going. If you were to take this and space it out, you would see that leads 1, 2, and 3 actually spaced out make the triangle, all right? And then you would see that these will show the point of reference in that triangle.
Hey, do we have that illustration here? Is that illustration?
It's in your book. If it's not in that book, it should be in the other book.
No, the other one.
Oh, is it not?
It might be in that.
You might have to go a little bit deeper back in your book, in like the 12 lead section. If not, I do know this PowerPoint is out there. This updated PowerPoint is out there. All right. So we talked about your bipolar leads. We talked about your unipolar or your augmented leads. We're just going to quickly talk about your precordial leads, just because I need to make sure you know how to place the 12 leads. All right, that's one of your check sheets and your little things where you place the 12 leads. All right. What they do is they give you a view of the left ventricle in certain aspects on a horizontal plane. Now, this is always something hard for me to picture in my head. But if you look at it, you look at the heart right there, it's giving me a view of each section of the heart, all right? And it forms the epicenter there where we're getting the view from the heart to that electrode, all right? So your placement of these is going to be very important. A lot of people have this wrong. And it actually gives you a poor 12 lead. You want it to where it's getting a direct look. That's the point of the 12 lead, is to look at that left ventricle. So on any given day, you may have somebody that does the 12 lead, and you'll see them do, if that's the sternum there, you'll see them do it there, 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 then there. All right? That's not the way that you do it. That is not the way that you do it. As you see here, you've got your two, your right of your sternum, and your left of your sternum. Then you place V4 in between you place V4 after V2, and then you find V3 right in between that. Then you move on around. Now, I always have to bring this up. What if you got a very well endowed lady, and you got to get a view of this, or a well endowed man? I mean, there are man boobies out there too, but what do? You are professionals in the health field. You just lift that thing up and you stick those leads under there. All right? You know they're going to be secure. Don't put it over on top of it. All right? The less that voltage has to travel through to get to that electrode, the better. All right? Adipose tissue is not a good conductor of electrical signals, so you want to try to have it as close to the heart as possible. Okay? So, when I place my leads, precordial or my chest leads.
Hey, I don't want to get off the subject, but can I ask a question? Alan, these, what you got there, what I see in the pictures that, you know, D2, 3, 4, they're all pretty close together. I thought that when we were talking before, it seems like we put the V2 on, then we go to V6, then go halfway in between, then go halfway in between those two, and put 4, 5, 4. Really, 2, 3, and 4 are pretty close together.
Yeah, I don't see any reason to do it that way. You know, just as long as you've got them in succession, it's not going to matter. All right. So you got your V1 on the right side of the sternum. V3. I still don't have the colors memorized. All right. But what I do say is do V4 and then find that point in the middle for V2, and then find that point in the middle between V2 and place when I drop V3. Then V4 or V5 and V6. All right. So what you have to imagine in your head right now is that we're kind of going to the middle of the left ventricle, and we're taking a view from that part out to each one of these. All right. So if my left ventricle is right there, all right, what I'm doing is on V1 and V2, I'm getting a view of the septal wall, which is higher up, right? Then I'm moving on around, and V3 and V4, all right, then V5 and V6, okay? So V3 and V4 are going to be your anterior leads, all right? So you're looking at the anterior wall of the left ventricle, all right? And then your V5 and V6 are going to be your lateral leads. So you're looking at the lateral wall of the left ventricle. Now, those will be easy to remember where you're looking at, because if you think V5 and V6, they're on the very side. So we're looking at the lateral or the side of the left ventricle. All right? Just think of geographically where these structures are located and what you're trying to look at. V1 and V2, we're trying to look at the septum. All right? A little bit higher up. V3 and V4, we're trying to look at the anterior. All right? Then V6, V5 and V6, we're looking at the lateral. Now, I thought you may have heard me earlier say that you're actually looking at 4 sections of the heart when you do a 12 lead. You are. But your precordial leads are looking at those, and then you got your inferior view, all right? And so that your inferior view would actually be your V2, V3, and then AVF, okay? Make a little more sense when we look at it all as a whole. As far as 12 lead goes, as of where we're sitting right now, that's all I care about you knowing, okay? That's all I care about you knowing is just really how to place it and how to place it correctly. Don't worry about studying up on axis deviation, all these different things. We got to learn the basics before we get to 12 lead. Don't worry about it, okay? Don't worry about these plus, minus, and all that stuff for right now, okay? So when they're right, you should see a surrounding from right to left, and we get a view from right to left of the heart, all right? When we do routine cardiac monitoring, we're just going to look at the lead 2. Routine cardiac monitoring is just going to be placed out of lead 2. If I don't see anything that is going to be cardiac specific, I'm just going to leave it on. I can monitor heart rate on there. I can make sure that the heart's still beating regular and all that, but I don't have to get really in depth with it. So my basic, when I've thrown them on the monitor, just riding to the hospital, lead 2, that's all I got to worry about. And again, why is lead 2 a good, just basic monitoring lead? What does it look at? Not the left ventricle, not lead 2. It pretty much, its axis goes down the normal SA to AV to the ventricles, all right? So it's not a perfect system, but it gives you a better look at that, okay? 12 lead ECG is going to be a standard that you do with monitoring if you've got chest pain, shortness of breath, things like that. And so you need to get used to putting a 12 lead on, but as far as interpreting goes, that'll come in April when we go over it, okay? All right. So let's quickly, let's look at this again. Repetition. I'm looking at the start of the P wave to the beginning of the QRS complex. What is that segment called? The PRI segment. The PRI segment. All right? Or the PRI, the PR interval. Okay? What is that time it's supposed to be? What is the normal time for that? Huh? Yeah, 0.12 to 0.2. Okay? So, let's just look at it together right now. I wonder if I can do this without screwing something up. Of course. And just look while you are. All right. I just cannot get this thing to work. If I start at the P wave, and I count small boxes, alright, 1, 2, 3, 4, 5, 6, alright, 6 times 0.04 is what? 0.24? Alright, so I've already noticed that that's not normal right there, alright? Because I'm expecting it to be 0.20, alright? Next thing I'm going to look at, my QRS. So if I go start here, 1, 2, 3, 4, alright, 4 times 0.04, 0.16, so we're already 0 for 2, right? It's got to be less than 0.12, okay? I'm just showing you this on here to show you, and it's probably, I don't know why they do that up there and it not be normal, but it's not, alright? So my P wave, I'm going to be looking at my PRI, I'm going to be looking at my QRS. Next thing I'm going to be looking at is ST elevation or depression. We're going to look at the QRS, back to the T, we're looking at the J point, and that's going to be the point where we might see elevation or depression. That point is actually supposed to be right on the isoelectric line, okay? Then T wave, what I'm looking for is really just the shape, alright? Is it upward? And is it rounded? Because I may have a tall spike T wave, and that may indicate an electrolyte imbalance. Okay? Then you've got a U wave that doesn't show up that often. Never seen one. U waves could be caused oftentimes by like hypothermia and things like that. All right, and that's a lot of times what may happen is that this may actually get confused with a P wave. All right. But for the basis of what we need to do, we need to understand, we need to learn, we've got to know that P to the T. Okay? Now there will be a few more steps. We're certainly not getting into anything else new today, but there'll be a few more steps next week that we've got to learn. Okay? Questions, comments, concerns about that? Okay. So, that's what we've got on electrophysiology, and that's what we've got on starting on monitoring. We're not going yet. I want us to go back and look at a couple things. So, just a quick review. I got a cell. You got a cell. We all got cells. Resting potential. Somebody come up here. Don't be afraid. Somebody come up here and show me right up here where the positive and the negative charge is. I hear you, Andrea. Let's give this guy a hand. Good job. Good job for keeping class rolling. All right, in my resting potential. There you go. That's good enough. All right, yep, we got it. All right, cool. So what has to happen in order for us to have a cardiac cycle? All right, we got to go into action potential, right? What happens in action potential? Now, it's not just 3 and 2. It's just with each activation, the sodium potassium pump. All right? Next thing over. Now, my drawing's not the best. All right. Not too bad if I say so myself. Somebody come up here and write the phases as far as the numbers. Somebody come up here and write the numbers of the phases up here. We're going to get through my review and all that, but if I don't have any volunteers, then I'll just stand here and look at y'all. Yeah, just the numbers of the phases. Yeah, and that's actually supposed to be a straight line. All right? All right. What's happening in phase 0 of our action potential? All right, so rapid influx of NAT. All right? So normally, in the resting potential, the inside of my cell is at a charge of what? Do y'all remember? Negative what? 70 millivolts. All right? So when that rapid influx of sodium comes in, my charge is going up, going up, going up. Right? To where we get to about 0 and then a positive 20 at our peak. All right? What happens when I get to phase 1? All right, so what happens to the sodium? All right, now you stop. All right, K leaks out still a little. All right, so I've reached my, what was that, the point of maximum impulse that it takes? Threshold. Yeah, so I've reached my threshold. That's what you do. You just scribble a bunch so that y'all don't know that I didn't know how to spell threshold. All right. So I hit my threshold. My threshold then propagated. And then we start having a slow drop. All right. So we start going down from negative 20. We start going down. All right. And then in phase 2 at this point, we also kind of called this the, it's supposed to plateau a little bit better. So I guess I gave you the answer, the plateau phase. All right, I don't think I spelled that right, so scribble. All right, but what comes in? So chi comes in. Chi comes in here. What is chi responsible for? All right, so this is where we got myocardial contraction. All right. So at this point, that was the whole purpose of us having the cardiac depolarization, right? We depolarized to where we got calcium to come in, and now we're having the cardiac contraction, the myocardial contraction. So now what are we going to start doing? We're going to start sending Alright? Calcium's leaving, sodium is leaving, and K is coming back to where our polarity starts to be even more negative, and then we get to here. Now, why is this represented as a flat line? Alright, so this is our resting membrane potential. Alright, and we're back to where we were. We're negative in the cardiac cell, positive intracellular or extracellular. Okay? Depicted, if this was the QRS, we know that the main part of the QRS, where we're actually having the ventricular contraction, is going to be in this phase here where our calcium comes in and we actually have the muscular contraction. Alright? Cool. Alright. Last couple of questions for you, then we'll ease out of here. You've got limb leads. So you've actually got 6 limb leads. What are your bipolar limb leads? Leads 1, 2, and 3. Why are they bipolar? Because they're crazy. No, because they have 2 poles. They got a positive and a negative. Alright? Our other set of limb leads are going to be what? Our augmented, ABR, ABL, and ABS. Now they're called unipolar leads. So they have one positive, then they actually have to combine the others to make a negative. Okay? Then you got your precordial or your chest leads, and that's going to be what? B1 through B6. Okay, okay. When I have a view of how the axis works with B1, B2, B3, the view of it actually forms what? Einthoven's triangle, right? So, last question. If I've got Einthoven's triangle, alright, so this is going to be my right arm, my left arm, and my left leg. Alright? If I am looking at an axis that's going from here to here, this is going to be what? From right arm to left leg. V2. That's or not V2, I'm sorry, that's lead 2. Lead 2. Alright? So lead 2, my positive is going to be where? Left leg. My negative is going to be my right arm. Alright? Now, I'm going to throw a positive up here. What is this axis here? Alright? And then, so now I'm throwing a negative here and a positive here. What is this axis? D3. And again, it's just all views of the heart. Okay? Alright. I think that is a lot of material for one day. You've got to read over it. You've got to study. So go home, read over this, but then you've got to get into airway mode for tomorrow. We will be going to lab, so make sure that you're not in open-toed shoes and you're protected and all that. Make sure you're dressed appropriately for lab.